Welcome back to Sports Medicine on Tap. My name is Brandon O'Line. I'm sitting at Neck of the Woods Brewing Company with my good friend Dr. Frey on a beautiful Tuesday evening. Dr. Frey, how you doing?
I'm fantastic.
It's good to be back.
It is.
Another little hiatus, if you will.
Yeah.
Just life gets in the way with things, and
Yeah.
I think this is our unofficial slow season, if you will.
Of course.
And
yeah.
just with the lull like without football going on, and like all the major sports are going into. At least NHL and NBA going into playoffs, so just a little bit of less content to kind of push out there for new.
It's not the dog days of summer.
No,
right?
no.
It's not July. And, but nonetheless, I guess with in this area, right, with the Sixers, sort of disappointment.
Correct.
With the Flyers, I don't know if I would call it a disappointment. I don't think the expectation was there.
There was no expectation.
All of a sudden, we're like, well, what's going on sports-wise?
Yeah. Just watching a bunch of the Phillies. But,
All of a sudden, I'm back on the Knicks. I grew up rooting for the Knicks. I got on the Sixers bandwagon, but now I'm watching the Knicks again.
You got to do what you got to do.
So we got ourselves an interesting topic, huh?
Yeah, we do. And so I will briefly discuss what we're talking about, and then we'll go into our special guest for the evening.
Yeah.
Just to go over, again, we talked about the NHL a little bit, but a little bit of a follow-up story here. We're going to touch back on Kris Letang and his heart issues.
Wow.
And with that being said, he just recently had heart surgery, and he was a topic of discussion back in December of 2022 on episode 63 with his history of stroke. So with that being said, without going into too much detail, who do we have tonight, Dr.
Yeah,
Frank?
so anytime we start getting outside the realm of sports medicine, right, like we start talking about some heart issues, we typically want to bring in a guy who knows a little more about it. Mm-hmm. So fortunately this week we have Dr. Arthur Ang. He is one of the docs for Virtual Medical Group. He's part of the cardiac surgery department and grew up in New York. Part of his life in New York, went to medical school at Albert Einstein Medical Center, or College of Medicine, which happens to be Montefiore, Montefiore is part of that system, happens to be where I was born.
There you go.
Yep. And then did his residency at Yale New Haven, and then out to University of Chicago, which is unbelievable place, unbelievable school, and has been with the Virtual Cardiac Surgery Group for the last 2 years. Thanks for coming on with us, man.
Oh, thank you. Thank you for the invitation, and thank you for the introduction.
Yeah, for sure. And like as I said, right, it's a little bit silly for those people who aren't really in medicine or haven't gone that route. But you go through medical school, you learn so much about medicine. Everything really other than orthopedic surgery. Honestly, it's not really part of your training in medical school. And then you do an orthopedic residency, and essentially what you do is take all that medical knowledge and just dump it out, and then you try to fill the cup back up with your orthopedic knowledge, because it's just how it goes. So when we get these kinds of topics that are not really sports medicine orthopedic related, I love having someone like you on the show to help us through it.
Oh, thank you.
Yeah, for sure. Kris Letang, defenseman for the Penguins, and what's really interesting about him is the fact that we did do this topic.
We have talked about this.
Yeah. And then now all of a sudden it comes out he has a hole in his heart, as they put it. Can you explain to us what that means? What is a hole in his heart?
Well, conceptually, we think of the heart as having two circuits, a right-sided circuit and a left-sided circuit. Now, let's just start on the right side.
Sure.
Typically, blood goes to the right side of the heart. Okay, it comes from the veins in the body. It then gets pumped to the lungs, where it gets oxygen. Okay. On the left side of the heart receives oxygenated blood, and then it pumps blood to the rest of the body, to your arms, your legs, what have you.
Right.
And in the usual circumstance, there isn't really a connection between the right-sided circuit and the left-sided circuit.
Right.
But occasionally, actually more than occasionally, there is.
Yeah.
Okay. And this actually has its roots embryologically.
Right. Yeah.
When we were all fetuses, there was a connection between the two.
Yeah. Why?
Well, the reason for that is when we're a fetus, we're sort of in an aqueous environment. We don't breathe, so we don't use our lungs.
You don't need them.
Right.
So there is a mechanism by which the heart doesn't send blood to the lungs.
Okay.
Okay? Instead, the blood passes through a hole in the heart called the foramen ovale, which in translation means the oval window. So it's a real structure. But when a child is born and takes its first breath, there are changes in the pressures of the heart. That hole then closes because a flap closes that hole.
Right.
Okay? And so then the foramen ovale becomes closed.
Yeah.
Now, it's been identified that almost 20 to 25% of the population.
That's a huge number.
It is. That
Wow.
closure is not complete.
Yeah.
And so there can be a small connection between the right and left side of the heart.
Right.
And as it turns out, that small hole in the heart can be a source of strokes.
And the previous show we did about Kris Letang.
Right. Yeah,
about stroke.
exactly about that is that, back in 2022 or November, he had his second stroke, and he was not just one, his second, right? And so a brief history to go back over 11 years ago in 2014, he was apparently found by his wife, and he was kind of alert but unable to function properly, and his main symptom was a little bit of dizziness and nausea. And then they kind of diagnosed with having a stroke, and then they found the hole in his heart that I guess he had, like you said.
But they did find it back then.
They found it back then in
Got it.
14. So then, per what I found online, he went on a 6-week treatment of blood thinners, had about a 10-week recovery period, and then he eventually returned to play for the Penguins, did his stuff, and then back in 2022, he started to recognize some symptoms. Luckily, because of his history, he kind of was quicker to respond to it, and he sought out treatment faster. I think the story is that he texted the head athletic trainer with the Penguins, said, "Hey, I think this is going on," and then they just kind of navigated that way, and got him the care that he needed. He was out for a little bit, and then he went back to playing, and he's been playing. And then this year, he's been playing a good amount. And then as of April 16th, it was reported on NHL.com that he went and had successful surgery to close this hole in his heart. So that's kind of where we're at now.
Procedure?
Yeah, he had a procedure done, correct.
All right, we'll probably get into the details of the difference on that. So for me, that brings up a few different questions, right? Like the first question is, if someone does have a PFO, patent foramen ovale, do they need to have surgery or a procedure to close it?
That's a great question. And in truth, most people who have a patent foramen ovale don't even know that they have it.
Right.
The hole that exists between the left circulation and the right circulation usually is so small. And the amount of blood that crosses that hole is usually of such a small amount that it's inconsequential. So no, the answer is no. The majority of people, one, probably don't know they have that.
Right.
And secondly, don't necessarily need treatment to close it, nor do they really need any other treatment, usually.
Just leave it be,
Yeah,
live
just
your
leave
life.
it be. Yeah, live your life.
So, in this particular situation, in 2014, he has a stroke, right? And they find it. Would it be considered unusual at that point not to do the procedure to close it and to leave it open? And it's not to be critical of any other docs or any, like, hindsight's 2020, right? Like of course. What's is there criteria that goes into the decision making process on whether or not, like, we better close it for this individual?
Well, you think about it this way. So many people have this connection.
Yeah.
Okay? And so if a young person has a stroke, you're really looking at reasons for why that stroke might have occurred.
Of course.
Okay? Now, if 25% of the population has this, can you attribute the stroke to that particular connection?
I see what you're saying, yeah.
So often, coming to that conclusion, we're making a decision to do something about that.
Yeah.
comes really by excluding other reasons that might exist.
Right.
Now, for Kris Letang, I don't particularly know if there were other reasons, but common reasons.
I'm going to jump in for a second, and here's our disclaimer. We do it every time. We're not talking about his specific medical chart. We don't have access to his medical records. We're just talking about these problems in general. So we really actually don't really know like what was actually going on with him. It's just talking about these issues in general, and he's sort of our launching pan for it.
Yeah.
But, all right, come on.
This information is never on NHL.com,
Yeah,
folks.
yeah.
Right, sure. So usually when looking for other reasons like arrhythmias or other structural problems of the heart, so it's difficult to say what was going on, but usually that's the thought process.
Right.
You have this particular finding, you
Right.
have this event. Is it true? Are they true and related
Right,
or not?
right. Well said. Yeah,
Right.
true and related. Yeah.
Yeah, it's a good way to look at it.
Yeah. So he did have that, right? Like he has the stroke and he gets back into hockey. For us more laymen than you when it comes to this stuff. We're like, guy had a stroke and he's coming back and playing again. Like that's pretty incredible.
Yeah, and I think if I do math correctly on this, he's currently 37. So about 11 years ago, he's only 26 years old, and that for such a young athlete at that rate, it's like you have a stroke. Whoa, what's going on? Like this is such a problem, and then it's like, oh, you have a hole in your heart. Okay, we'll just do some treatment. We're not fixing it. Just go back out there and keep going.
Yeah, I know. It's a little surprising, but he also then had another stroke, like you said, in 2022, correct?
Yeah.
Yeah. But that was a small one, if I remember.
Yeah, it was kind of
TIA.
reported as like minor. It wasn't as severe as the first one. I think because he recognized the symptoms earlier and was able to act faster, so I think it helped with that. But it's just interesting that someone with this caliber of athleticism has this heart issue, is able to get to this level.
Yeah.
Has this heart issue. It's kind of just, I guess, kind of kept at bay for the most part, and then he continues to play for another 8 years before he has any real problems outside of, I think, normal bang-ups of hockey. I think he had some other neck surgeries or other things like that, but nothing truly related to his heart or his strokes.
There's 3 or 4 questions that really come to mind for me to ask you about this, and I think we'll try to work up to it. The first one is, in terms of having the PFO, is how do they pick it up? What would be the best test or the best study to? In this scenario, clearly he had a stroke at a young age. He gets more of a thorough workup. What is the test? Is it something that's seen on an EKG? Does it take a higher level test or than that in order to figure out that someone has this?
When there's a hole in the heart between the left and right side, given the usual pressures in the heart, given the usual compliance of the chambers of the heart, there's a tendency for blood, if it's going to move from one circuit to the other, to move left to right.
Because it's a higher pressure system.
Right. So there's a tendency to move left to right.
Yeah.
In the PFO, usually because that is such a small volume, that additional volume on the right side of the heart is very well tolerated. And that's why many people can go for many years and not know that they have this at all.
Right.
Okay? However, there are certain circumstances where the conditions of the heart can change, even temporarily, where flow can be favored in the opposite direction, from right to left. Now understand, whatever moves
as
from
a fetus.
right, right, exactly, as a fetus, but this now as an adult. But if it moves from right to left, then anything that's in the right side goes to the left side, and the left side is a direct connection to the rest of the body, including the brain. All right, which just, that's where strokes occur.
Right.
All right. So sometimes that connection can reverse. And so this can be identified on, say, an echo study, where we use basically ultrasound waves and we can actually look at flow, okay? But also what we can do, and this is sometimes done, is we actually inject bubbles. Now, these bubbles are just markers. These are just to be able to show us that blood is the direction in which way it's moving, okay? And so you can sometimes demonstrate that flow from the right side to the left side. Right. Now, it's fairly specialized testing, and it's a test that you really have to kind of evoke that movement, because the usual pressures don't favor the blood flow to go from right to left. Rather, it tends to go from left to right.
Right.
All right.
I think about a plumbing system, right? Like the drainage system, like the water coming into your faucet is coming at a high pressure. The drainage at the bottom of your sink is nice and low pressure. It's easy. And so that makes a ton of sense. It's funny that you said that, and all of a sudden, it all makes sense to me now. Stuff that I was trying to put together back in medical school, but like the flap is on the I guess it would be on the left side, right? So that when you're a fetus, the pressure's higher and it blows the flap open. It keeps the hole open, and as soon as you take a breath, now the pressure on the left side gets higher and slaps the flap shut and closes the hole. It all makes sense to me now. 30 years later.
Big moment. It took us all the way to get to it, right?
But so you have these evocative tests, and so you can be building evidence that the source of these events is this PFO.
Right.
If you can elicit that kind of movement through evocative testing, then you have more evidence that you really have the substrate for such a thing to happen.
Yeah. So for the so it's kind of go with what you were saying. For the most part, this is something that just, unfortunately, something kind of has to happen before you kind of find out about it. Whereas I know in a physical standpoint, for pre-physicals for sports performance, I've been in situations where we've done EKGs on everybody, but it's doing an EKG on everybody isn't going to find these holes in the heart per se. That's going to
exactly what I was getting at.
That's going to help other things. I mean, there's going to be things that you can find from a scanning, like a pre-screen EKG, versus what we're talking about right now. Like you mentioned, something that has to go over more diagnostic imaging and get an echo done.
Yeah, next level.
To go up a thing. So this is not something that you're going to see. It's not going to become the standard practice of physicals for sports. Not everyone's going to now start getting echoes done.
Even EKGs are not standard.
Standard, correct.
Right? There has to be a finding before going down that road.
Yep.
For pre-participation sports physical. Right. But yes, and that's exactly the point I was trying to drive at. You're right. It's not even picked up on an EKG. It is the sort of the next level, sort of a provocative test.
No, and typically, some cardiac abnormalities are picked up on physical exam. You can hear something.
Right.
But typically, a pain foramen valve is not. There is not, in general, enough flow. And usually the sounds that we hear in the heart are sounds that are related to increased flow or restricted flow.
Right.
And the PFO really doesn't have a sound.
Right.
And
what was the name of the tapes? We're going way back to medical school. And he was a Georgetown guy, which is where I went to med school, who had all the tapes, and we'd have to listen to the different murmurs, love, and then the swish, and when it was.
There's really not for a PFO.
Right. There's none of that. Right.
And it's funny. Yes, you can't find this exact thing we're talking about, like a PFO on from just listening or whatever. But it's interesting where I've been in situations where we have these pre-participation physicals, and our doctors hear something, right? And it's then we get further workup where you get the further workup, we're going to, do a cardiology workup just to make sure everything's fine. And then you hear all this pushback from their support system, whether it be family or coaches. What do you mean we're holding this person out for this long because someone heard something? But they've been playing sports all this time, right? It's well, yes, they have, but now we're in college, so it's in theory a little bit of a step up from high school, right? So, and then yes, we're going to go in a little bit more depth. And if, as an athletic trainer, my doctor says that they heard something on the heart, and that they need some more workup, I'm going to follow what they say pretty much and go with that, obviously. But, because then who's to say that the one athlete that we have, again, this is not the exact saying because it doesn't present this way, but a doc hears something on the heart, we do some extra workup, they find a PFO or they find something else. It's like, okay, well,
cardio.
It was worth waiting the 2-3 weeks or potentially, suspending your athletic career to save your life kind of deal.
Yeah.
But these things have a place and time, and it's like they're really beneficial when you catch these things early.
Right.
However, this is not something that you can catch in those situations.
This would be one of the ones that sort of slips under the radar on that.
Right.
If the number is 20 to 25% of people have this and don't even know that they have it, is it surprising that Kris Letang, who is a really good hockey player, he's not just like an average guy, he's had a really, really pretty distinguished career, could get to that level of athletics despite having this issue, this hole in the heart?
No, not necessarily, because as I said, the hole is usually quite small, and so it's not as though the extra volume that might go from left to right is really a hindrance to his athletic performance.
Yeah,
I think potentially for the issue here is that it doesn't take a large amount of anything to go from the right side to the left side to go to the brain.
Right.
That's not a volume issue.
Yeah.
That's more of an issue of there's a small something that just got off with the wrong side.
Yeah.
And so I think that it's two different issues in terms of this is not, a lesion or an abnormality or a thing, let's call it that. Because it's hard to say it's really an abnormality if it's present in 25% of the population.
Right.
But it's not something that necessarily would hinder, in and of itself, athletic performance.
Right. We started talking a little bit about this before we hit record, and we put the kibosh on it because it's always better to talk about it the first time when we hit record. There's another, like if you think hole in the heart, the two things come to mind, right? Like something called an ASD, an atrial septal defect versus a patent Freeman ovale. What is the difference between the two?
That's a great question, because they are both described as holes in the heart.
Right.
And they tend to be described as holes in hearts between the same chambers of the heart. So they exist in the same area of the heart. Okay, they exist in what's referred to as the atrial septum. It's just call it the septum.
Yeah.
Well,
like a wall.
Embryologically, there are different parts to that septum, and in an ASD or an atrial septal defect, one or more of those parts just doesn't form correctly, and so you have a defect. Okay. In a PFO, all the parts form correctly, but when that first breath takes place and that flap comes to close, that closure just isn't perfect. It's not exactly a perfect closure. Imagine a window that has all the panes and everything, and you try to close it and it's just not quite tight. Okay,
a little bit open at the bottom.
That's a PFO.
Yeah.
Yep.
But imagine if there is just no glass in the window, it's a big hole.
Right.
Then that's an atrial septal defect.
It's a great analogy.
Okay, and so we consider atrial septal defects as a true, congenital at birth defect, and that occurs, I don't know, probably in 1% of the population. It's
far less frequent.
It's less than perhaps 1%. Okay. But the PFO, which is all the parts of there, they just haven't come together properly. That is, again, it's hard to say that it is congenital in the sense that it's from birth, okay? But again, we all at one point had a patent foramen ovale.
Right.
The people who we say have patent foramen ovales as adults, that just hasn't closed along the same lines that the other, say, 75% of the population have.
Yeah.
That's all.
Now, with that being said, is this something that now again, to go to the window analogy, I think is great, right? Like
perfect.
It's just a matter of the window not being closed all the way. But if with a PFO and the window's not closed all the way, over time can the window get open more? Like does the hole get worse
That's a really good
over
question.
time? Like is it just something that it's tolerated, but can it get worse?
A PFO?
Yeah.
In general, that's no, in general it doesn't.
It doesn't.
It doesn't get worse.
Yeah.
Okay. It usually is quite small.
Mm-hmm.
But as I said, again, you can have problems with the flow reversing through them. Atrial septal defects, while they may not necessarily change in size and say get bigger with age, there can be changes in the compliance of the heart, so that whereas that kind of left to right flow might have been tolerated earlier in life, as people get older, there's changes in the compliance, and those may become more significant.
Right.
But again, that's a problem of, let's just say, a volume of flow issue, okay, which is different from the PFO issue.
You may be answering one of the questions I have coming up ahead of time. Actually, let's get to it right now because you may have just answered it, right? Like, so my question was going to be, right? So Kris Letang has a stroke, and you kind of got into why, they don't just do it right there and then and fix it right off the bat. And then he did. He had a second stroke or mini stroke or TIA. It's kind of unclear, but it definitely he had some issues. He had some symptoms, right?
Right.
And then here we are now, 2-3 years later, and he's actually undergoing a procedure to close it. So my question was, why? What happened now? Why do it now as opposed to after the first, after the second, or sometime in between?
Well, again, I don't know for his particular circumstance,
Yeah.
but clearly, if he and again, I'm not sure exactly after the first event, what they did to try to reduce his risk of having another event is. I believe I may have heard that he was on blood thinners or something like that for a while.
Yeah.
But it's clear that whatever was done didn't prevent a recurrence. And so again, now you're talking about when you're sort of weighing that true related or unrelated.
Right.
Now you're talking about you've instituted a treatment perhaps for something else. You have had a recurrent event.
Right.
And so again, the calculus changes somewhat. It can change. And it sounds as though the PFO as a cause, for the events, basically was being, I'm not saying emphasized, but it was felt that was
a contributing factor.
Much more of a contributing factor.
And I think this is something, again, to go back to what we said, like we don't know what, who knows this.
The devil's in the details here. Yeah.
Something's going on at practice. He's lagging behind in practice or whatever the case is. Or I don't really know. Like, I don't even know how this kind of brought up. It was just kind of reported that he ended up going, he's out and he's going to go have surgery or whatnot.
Yeah, he missed, I think he missed the very end of the season.
And I think what this being said too is, which is interesting, is that, he signed with the Penguins until the 27-28 season.
Yeah.
This year alone, he's had 9 goals, 21 assists, and 74 games for Pittsburgh.
Yeah.
His lowest point total over a full season since 2009. So again, a dip in production, right? Granted, he's 37 years old.
Right.
However, he also averages the highest ice time of the team of 23 minutes.
Seriously.
23 and a half minutes per game.
Yeah.
So it's just like, he's probably one of the
He's
oldest guys in the room.
Still pushing it,
and he's getting the most time on ice.
Yeah.
But he has a little dip in, scoring production, which is, not to say that it directly relates to his heart, but we don't
know if there was
know.
Another event. We don't know if they just said, hey, maybe you don't have quite the same gas that you previously had. And maybe it's not just age. We don't know what the detail that led to that.
I think with that just brought to the question: is there something that would be like a serial test that's done every year for someone like him like, let's do this every year to kind of assess the situation of your heart, and like maybe that something has changed and now we go and get surgery? Is there something that you would like track over time with someone like this?
Probably not so much for a PFO.
Right.
It would be more for for symptoms.
Right.
I imagine it was symptomatic.
Yeah, there's got to be something. There's got to be some symptoms.
What would be some of the symptoms that would start to bubble to the surface for him? Obviously, if there's a stroke, that's a whole set of symptoms. But short of a stroke, do people have symptoms related to just the PFO alone?
Generally they don't.
Okay.
Generally they don't.
Fair enough.
It would probably be the actual stroke itself or stroke-like symptoms.
I wonder if another thing happened. I wonder if there was another event. Like we don't have access to his chart, but I wonder if like something happened, a little event, and they were like, we got to address this.
I'm going to go out for a wild card idea, right?
Sure.
Like what we mentioned before. We kind of briefly talked before the show started about wearables in the world of sports. Like, who knows if they have some kind of wearables and there's something that happened with his heart rate under exercise or when his practice strain has changed over time, and like, I don't know, a practice, say if you put it on a scale of 0 to 10 used to be like a 6 for him, and all of a sudden he's rocking at 8s and it's 8 out of 10 just difficulty for him and something's changing.
I don't know. Is there any criteria or anything like that? Not that you're aware of either, right?
No.
No. That's just a way out there idea of mine, or a thought, if you will.
How is this normally fixed, normally addressed? If it's determined, all right, we want to try to close that hole. How is it done?
Yeah, I mean the most common way probably now for closing a pain foramen ovale is or PFO is through a sort of interventional procedure.
Right.
So it's a procedure which can be done through the blood vessels.
Right.
Where basically a plug is placed to seal that hole.
Yeah.
Yeah.
Fix a flat.
Exactly.
Almost.
So
Right.
I think what is interesting too is I just tried to Google, like as we were talking, like why he had the surgery now.
Sure.
The only thing that kind of made sense is that they were kind of out of playoff contention and that they had a longer off season. So that would mean that he'd have more time to recover, and he just kind of went with it and did it then.
Very interesting.
But, I mean, I don't know what their playoff situation was in the last couple of years since 2022.
No, I think they have made the playoffs.
Right.
I could be wrong. I'm going back to
we're just
the memory banks here, and they're always right there. Like they're always a good team right on the cusp of the playoffs,
Right.
and I do think they have made the playoffs for the last 2 years. Maybe I'm wrong about that, but it is interesting. I don't think of this, and it's not what I do, so I could have it completely wrong. But I don't think of this as a super long recovery. I even went so far as to sort of correct the terminology from surgery to procedure. Mm-hmm. Is it typically a long-ish recovery?
Well, I think what you said is correct.
Yeah.
Actually, no. Actually, the procedure itself to place a plug, it's actually usually a fairly quick procedure. In fact, it's a procedure which is often done within the space of a day.
Yeah.
I mean, people often don't even spend the night in the hospital.
Oh,
wow.
Right.
Are they on anticoagulation after the procedure?
Often they are at least
the
antiplatelet agents.
Right.
Okay, but the other issue is these plugs that are placed. They're made out of a special metal, sometimes with a sort of mesh covering.
Mm-hmm.
Yeah.
But they do take time to integrate. So they're placed, and they can plug the hole, okay, but to get the full result, it takes time for the tissues of the heart to integrate around that plug.
Like epithelializing a
Exactly.
stent.
That's exactly right. And so that can take a while. Now, for someone in the usual walk of life, they have this place. It can be a day procedure, and they might be told by their doctors, why don't you go out and, in a couple of days, get back on with the rest of your life.
Right.
Mm-hmm.
But this is an athlete,
Right.
okay, engaged in. I'm not a big hockey fan, but I know it's a contact sport.
Oh,
Yeah.
Okay, and so someone in his position would be subject to, let's say, unusual stresses.
Right.
Okay, if you're playing and you get hit head on, or somebody is, another player, 250 pounds is skating straight at you, and
a little more risk,
and maybe actually, rocking you a little bit, might
trying
be
to hurt
part
you.
of the intention. That's a different circumstance.
Mm-hmm.
There, anything like this, you would certainly want to be well integrated.
I would even think to the level of, if I remember correctly, for a stent, until it epithelializes, you have to be very careful. You have to be on the platelets. You don't want it to start to form a clot. And so I don't know if that holds true for this plug, but I wonder if that could potentially be the issue, that he needs to be on platelets for a certain amount of time after the procedure. And then maybe after the epithelializes, I don't know if he's able to go off of platelets at that particular point, but that could be a reason why they wouldn't have wanted to try to do this earlier in his career.
Yeah.
Number one, and number two, that could be a reason why they trying to wait for the appropriate gap, the appropriate time to try to do it. And I guess second stroke or second symptomatic event, they're like, all right, we got to be able to do this when as soon as we can do it, kind of a thing. It's sort of a justification.
Yeah, I think so. Per the report that I found on NHL.com, they're saying that his recovery time is roughly 4 to 6 weeks. Would you generally agree with that? Is that about right to? Now, is that 4 to 6 weeks for the average person, or are we talking 4 to 6 weeks to get back to elite hockey player level?
And then, sorry, answer that, and then I guess I'll do my follow-up.
Yeah, that's I think that it's more to I don't know if it would be long enough to actually be in full competition.
Right.
All right, but it's certainly longer than you would take to clear the average person.
Yeah.
But yes, there is a certain time period that you would want the person to be on those kinds of medicines to prevent clots.
Yeah.
Because, whatever you put in the heart, and it's a combination of mesh, it's a combination of metal and mesh, or just metal itself, that's given the various devices. Those devices are thrombogenic. When I mean thrombogenic, I mean they're not exactly compatible with your body. And so they have a tendency to evoke a response. And that evoked response is clots to form on them.
Right.
And that exists until those devices become, and you use the word, endothelialized, before they become covered with your own body's cells.
Yeah.
Right.
Okay, so there's a certain time period, one in terms of a sort of surface enhancing standpoint, that you want it to be compatible and not form clots. And then also you want it to be in terms of integrated in that sense, because you don't want displacement. You don't want something, God forbid, knocked out of position.
Man, that sounds bad.
Anything to move around in your heart does not sound like a good scenario.
So you don't want migration of the device or embolization or anything like that, because just this particular device, it's sitting in the heart, and left or right is not a good way for it to travel.
Not good. Yeah, for sure.
So I think with that too is with the timeline of just the report says 4 to 6 weeks, but in reality for him, say middle of April is when he had the surgery. He has about 5 months until training camp. I just kind of did a quick Google of when training camp starts, and says, September-ish, late September, and he's a veteran, so they can come in a little later. They come about 2 weeks before the first game of the season, and that's when they do their stuff. So he's looking at 5 months, not like he's not
got
trying
a
to
nice
make a
little
comeback.
window.
He has a good window. So with that being said, to kind of re-ask the question, is 5 months more like reasonable for him to be back at hockey level?
Yes, I would think so. Now, obviously, I'm not an
Yeah,
expert.
treating physician. Sure.
But yes, I think that's quite reasonable.
Well, and the platelets generally are the antiplatelet therapy, they put them on. Is that generally temporary, or is that frequently rest of your life treatment once you've had this placed?
It's often it's a sort of double therapy. It's like a couple of platelet agents, antiplatelet agents that they're on for sort of a month or two, and then they might be reduced to, say, aspirin or something like that long term. So it's gradually often ramped down. Okay, basically to a medication that there are many people who would take aspirin a day,
right?
And while it is an anti-platelet agent, it in general doesn't prevent people from pursuing even contact sports.
Right. It's perfect.
Crazy.
And that makes a lot of sense.
Yeah.
Like, honestly, all these questions that arise, you're like, why? Like, all of a sudden, all right, now it all makes sense.
Yeah.
There's the logical reasoning behind it all. Right, for sure.
Excuse me. Yeah, and I think it's just generally an interesting scenario, right? Like this guy, and it's also I guess where my brain is going is that he's 37 years old. Right. Is this something that you would venture to say could be extending his career? Like, is there something that I don't know, like, do you just say, hey, you could probably retire and be done with it, but because of your nature of your profession, we should get this done, and maybe it extends you till you get to the 27, 28 season? Or, like, I don't know, like, is it, not to say is it necessary. Again, we don't know.
No,
but you know what I mean? Like, is it something where, like, he could have, again, we don't know the exact details, but in theory, like, could he have not gotten surgery and just went about his normal life, and because his stress of not being a hockey player is no longer there, that he probably wouldn't have any issues? Or this is something that, no, you got to get it fixed to continue on with life? Does that make sense?
It does. My gut reaction to that, and you might be able to comment more on this, would be that he's already had 2 events that we know of, right?
Right.
And then also like you said, he led the team in minutes, right? I don't know if it was the entire team or the defense in minutes,
right,
on ice time, right? Like through the year. So even though he's not a young buck out there anymore, clearly he's an impactful player on the team, right? So there's a little more to give before his career is over.
Right.
If they, and I think that's sort of a debatable thing, right? Bronny James, right? Like we went through the whole argument. Like, is it worth it for him to come back after having a cardiac event, on the basketball court?
Right.
Come back, bring him back. Like, should he just retire? What is he doing it for? And he didn't, right? Like, so I would think with Letang, the same thing. Like, can he just retire? I'm sure he could. Does he want to? Probably doesn't. Is there more in the tank? Probably. He's a valuable player on that team.
Right.
So if they can do something to reduce risk, mitigate risk while he continues to play, without a whole lot of downside, and this is the opportunity they're waiting for, right? Get a couple extra, hockey playoffs can go for months. They're not quick if you go far.
And I didn't look into it. Again, this is, not to go off topic, but like in regards to being eliminated, I don't know when they got eliminated from playoff contention this year. If it was earlier,
I think they were middle of the road.
Yeah.
I think they were like at a reasonable. I didn't follow super closely, but I think they were in contention down to the last week or two. Yeah, that kind of thing.
Again, this topic tonight is a follow up from previous episodes. So I added,
and it's awesome. Like, this is the stuff we don't get to talk about. So it's not often we're on a show where like I'm learning a lot. I love it. So thank you. Yeah.
I know, and really, this is. Tonight is kind of really cool because as an athletic trainer, I don't really have opportunity to sit down with a cardiac surgeon and talk about these kind of things, which is just crazy.
Amazing.
And it's wild that we've talked about this particular athlete before
and not discuss this topic.
Exactly. But just to follow up on some other athletes that we've discussed previously, last episode, real quick, Damian Lillard, we went into a long discussion about him. He had blood clots in his right calf. Right. He was out for about 4 weeks, got cleared to return in like what seemed super fast.
Very fast.
Goes back on the court, attempts to push forward, and then his left Achilles just gives out and tears his left Achilles on the court.
The first thing I thought was, I hope that was not the same leg as the DVT.
I did too. I watched the video like 6 times. I was like, wait, he grabbed his left leg. Oh wait, what did we just talk about the other week? And I made sure. I was like, oh, not the exact same leg.
Yeah.
Who knows if you want to argue how it was related to it? If it was, I doubt it. But
he's an older player. He's 34, right? In the game of basketball, it's a jumping, landing, cutting, fast start, fast stop injury.
After a little bit of rest too.
After a little bit of deconditioning, rushing back to get back for the playoffs. I don't think it was anything DVT related. I don't think it was a misdiagnosis. I think he just.
I think this is unfortunately like kind of similar to a couple years ago when Kevin Durant did the same thing with the Warriors. Like he had a calf injury, came back way too soon. Yeah. His Achilles was next thing to go.
But that's even calf injury. This is the other leg.
Yeah,
you know what I mean?
Exactly.
Right. Like this is just
pure unlucky.
Bad luck.
Like bad luck.
Yeah.
And then last, I think that's unfortunate news, and that unfortunately Lillard is going to have to figure that one out and come back with that.
Yeah.
But a real big time off, if you will. Gabriel Landeskog for the Colorado Avalanche just returned to play in the playoffs. He hasn't played hockey since 2022 in June.
Amazing.
He essentially took 3 years off to get a cartilage and meniscus transplant.
Right.
And I didn't read too much into it because this is just a blurb on our outline. It's not our main topic, but
we may cover this one.
We may have to cover this one again because I think he even scored a goal in his second game back, and I think it was an impactful goal. If I'm not mistaken.
I don't know if anyone's ever come back. I would have to look into it.
I think the only
professional sports after a meniscus.
I think the only other person would be Lonzo Ball, who we've talked about in conjunction with Gabriel Landeskog together.
At the same time, same show.
And last time we talked about Lonzo Ball coming back, and then he decided to go and have some wrist injuries and was out again, so we kind of jinxed him a little bit.
Yeah.
But the Landeskog story is crazy because he's their captain of the team.
Yeah.
He was out for 3 years.
Yeah.
He comes back essentially to a standing ovation. Does really well in the playoffs in a very heated environment.
Yeah.
Does pretty good. I think they lost his first game back, but I think he was impactful and scored in the second game.
Yeah.
Again, loose research on this one. This is not how I hone in.
We'll come back to this one. Yeah.
But just some follow-ups on previous things that we've talked about, because again, tonight is a follow-up show, if you will, with a little bit more detail and more, more expertise, if you will, in regards to this specifically. Yeah. So
wind us down.
Yeah, might as well wind us down. We forgot our
Sourfest.
Yes. I will talk about that in a second. So just to give a quick shout out to our sponsors, Virtual Orthopedics and Spine. They have you covered from runner's knee to dog walker's hip, yard work back and laptop wrist. They have a doc for that. Virtual Orthopedics and Spine has over 120 providers, over 20 PT and rehab facilities, and more than 25 surgical centers all across South Jersey. So find the right specialist for you at virtual.org/ortho. Neck of the Woods Brewing Company, as mentioned, they always serve us the best beer, and they have Sourfest coming up on May 17th from 12 to 8 p.m. here at Total Turf in Pittman, in the back, in the parking lot, in the tasting room, all over the place. They have shirts on sale. Tickets are on sale, pre-sale now, I believe, so you can go on their social media pages and find information about that. Yep. And Timber Rail Production, they help us put this together, all the audio and video and all that great stuff that Dr. Frey and I don't do very well. So, Kyle, thank you for that. Dr. Ng, thank you so much for coming.
Yeah, thank you very much. Thanks for coming on, man.
Yeah, it was a pleasure having you.
Thank you.
Yes, thank you so much. Definitely way outside of our normal discussion, and this is I think this kind of stuff kind of makes the umbrella of sports medicine so wide, right? Like it covers a little bit of everything, and yes, in these regards, yes, these are athletes, but sometimes they do have to come down to the office to a cardiac surgeon, and some things get a little different.
Goes outside the realm of what we're used to.
Yeah, exactly. Sure. It's not just a sprained ankle. This is a lot more than that. So anything else, gentlemen? I think we're pretty good.
Next man.
All right.
Thank you.
All right, folks. Thank you so much again, and we will see you next time. So have a good one, and talk to you soon.